we'll move on to the next topic by Dr. Selvamani, imaging role in bifurcation PCI.
Yeah. Good evening, everybody. It's really a pleasure being here, and I thank Dr. Srinivas Kumar and the organizers for calling me here. And I'll just go to the topic directly. And coming to the issue here today, OCT in bifurcation. How do I do this? See, basically, apart from routine things like plaque burden, stent size, stent landing, and calcium, lipid-rich thin cap, we generally use OCT in bifurcation to decide whether to do a crossover or just a simple ostial landing. That is one point. Whether it's a single or a double stent strategy, and to predict the side branch closure and size the crushing balloon sizing, and to look at the metal deformed carina, optimal side branch cell crossing, and of course final kissing balloon, and whether to kiss in provisional stent strategy, and of course for complications. So these are my general approach. When you look at this case here, this patient actually had a proximal LAD lesion and some disease in the LAD here, and a very tight diagonal disease here. So what our strategy was to decide whether to treat the LAD and what, but the FFR was negative in the LAD, RFR as well as FFR. And although OCT in the LAD showed a very critical lumen area somewhere around 1.8 and 1.9, but the FFR is negative, but we just thought of treating only the diagonal disease here. So when I did a OCT in the diagonal, you see here, what we can see is we can make out what is the area at the landing zone and what is the diameter of the main vessel as well as the side branch. And you can decide whether to do a crossover or just land on the ostium so that it is just an ostial landing. What I do is you just co-register and you mark the ostium of the vessel on the angio co-registration, and then you place the stent exactly on that. See, this is how I have placed the stent. If you go by angiogram, generally what we do is we tend to pull the stent till further. Probably you might overhang, thinking that we'll miss the ostium. But when you use a co-registration, it is exact landing usually you get. See, this is what I have stented using this angio co-registration. And post-stenting, you see here, it is an exact ostial landing. The stent is not extending into the LAD there, just landed in the ostium of the diagonal with a very good result here. So this technique, what we call it as a boom technique, is very, very new, and probably you can use it. It was actually presented in TCT 2018. It is bifurcation and ostial OCT mapping. What you do is you just select this ostium and then place it on angio co-registration. This is the precision. Usually it is around 70% within 1 millimeter precision, and around 90% in 2 millimeter, and almost 100% or 98% within 3 millimeter precision regarding the stent placement precision decision making. So it's a very useful technique, especially in bifurcation for ostial as well as bifurcation overlap, where you can minimize the overlap. Still, you can avoid crossover. Look at this case here. We always had a discussion whether to have an ostial landing here or to do a crossover. So in such case, what generally I do is, after doing a balloon dilatation, you do a OCT. In this case, what has happened is, you see here, the lesion is actually from the ostial LAD is extending into the left main. So in such cases, it is usually better to do a crossover when there is a disease extension from the branch into the main vessel. Apart from that, he had a dissection there in the ostium extending into the left main. So in such cases, there is no option. Probably you'll have to do a crossover and just treat it over. Coming to side branches here, see this, the patient had both the vessel's FFR was positive, and you do an OCT there, then you look at certain characteristics here. So when you look at the longitudinal view here, this is the carinal angle, which is very important. If it is more than 30, it is better. If it is less than 30 or somewhere around 15, 20, the chances of side branch occlusion is very high. You look in for the plug characteristics just opposite to the takeoff of the vessel. If there are calcium, chances of occlusion is very high. And then you look for carinal angle to branching point distance. If it is more than 1.7, chances are very less. And more than that, if there are huge lipid burden at the carina, chances of side branch occlusion is very high. And more important is size of the distal main vessel. If you oversize your NC for this, probably you will close the side branch. So look at this example here. There was a tight lesion in the diagonal as well. And this is the OCT here. So here, there are two vessels taking off. Actually, it was mistaken. You see here, there's a very small diagonal and a big diagonal here. We thought probably this is the main vessel, and then the distance was miscalculated. Actually, there is a pointing carina here, and then the distance between the branching point and the carinal angle is very less here. And there was calcium opposite to that. So when we stented, the vessel got occluded here. So this is what happens. The vessel has occluded now. And it's a very clear description. Any pointing eyebrow sign or a pointing carina, calcium opposite to that. And if this distance, actually branching point to this distance, if it is very less, the chances of side branch occlusion is very high. Coming to crushing balloon size, it is here, this, I was doing a DK crush. So I have crushed with a 4 NC there in the side branch. And after this crushing, when you do a OCT in stent rendering, if it picks up something like that, that means it is not an adequate crushing at all. Generally, in stent rendering after a crush, OCT does not pick up this metal here. If you see something like this, probably it's not an adequate crush. So I have taken a bigger NC balloon there and then crushed it. And after crushing, you see here there is nothing, and then you see a very thin crushed part of the stent here. And sometimes you see still lesser amount of stent in a well crushed stent there. Coming to kissing balloon sizing, it is very, very easy. You can forget all the fillet law or Millet's law. What you should do is you size your side branches, you balloon according to the distant reference. So you take your balloon sizes according to the distant balloon, and then you dilate it. It is so simple. The main vessel will definitely tolerate. And of course, for pot, you can measure the main vessel and go with that size. So sizing of kissing balloon is also very, very easy. You need not calculate or look into the fillets law and all. Coming to ideal cell cross, it's very, very important. Whenever you stent here, usually restenosis occurs at the ostium of the circumflex, that too at the carina. But generally, otherwise, in a non-stented area, the plaque burden is in a non-carinal area. Why does it occur is when you stent it, there is a strut accumulation, and there are a lot of reactions occurring and flow dynamics are altered. We have a lot of papers saying that optimal wire crossing in the side branch and bifurcation stents, and they have been followed up also. Whenever you get a side branch opening like this, when there is a link across it, probably long term, your ostial opening of the side branch will be reduced. We'll see how it happens. When there is no link, probably it is better. There is a paper by Akumara who, what they did is, they studied the presence of link-free type as well as link-connecting type carina. After you see a kissing balloon, if it was like this, they selected such cases. Around 54 cases were studied and suboptimal 51 cases were studied. And they found out the reason for that struts across were guide wire not crossing distally, that is one, and angle between the side branch and the distal main vessel, and proximal main vessel reference. These were the important factors. When you do a distal crossing, what happens? You see here, even in a provisional stenting, which is very, very the common, probably around 80 to 90% of bifurcation today, we treat with the single stent strategy. So in there, if you cross distally and you dilate this, what happens is there is a good coverage of the ostium and the stent expands like this. If there is a proximal crossing, what happens is there is a distortion of the main vessel stent there causing a problem. So that is the reason why you emphasize you go with a distal crossing here. And OCT clearly shows that. See here, it is a very distal cross there, can clearly make out. And once you see here, you can document very clearly in the longitudinal view also that what cross it is. It is a very clear distal cross here. And you can reconstruct in the 3D mode also. Even in the distal cross, you can make out in which cell it has crossed. So here it has crossed a very remote cell. Probably this may not be a very ideal cell, even if it's a distal cross. Probably if you want, you can change the cell and then go with a better cell there. And during provisional stenting, should we do a final kiss? That is a matter of question always. In this case, you see here, after this provisional stenting, if there are metal like this across the side branch, and there is a lot of connectives across the side branch like this, it is definitely not ideal. So you do a distal crossing. But in an anatomy like this, angiographic crossing of distal cell may not be very, very easy. But otherwise, in many cases, angiographically itself, you can get a distal cross. But in an anatomy like this, it's very difficult. But the OCT clearly shows it's a distal cross here. You look at the OCT here, and it shows it's a distal cross, and you can confidently go and kiss there. And you can reconstruct on the bifurcation mode also, and you can look into that what cell it has crossed. And even in the run-through mode, you can clearly make out the cell where you are crossing. And this is after the final kiss. You can make out there are no cells there, and the bifurcation spot is exact with good opposition there. So even after pot, side pot, see, this is before the pot, side pot, and this is after. You can clearly make out that
Dr. Selvamani, you can conclude. Already we are
sure,
running
sir. Last 2
minutes.
minutes. And this is a follow-up case here when there is there are cells where we did not do any kissing there. And once we did that, 1 year follow-up, you see here, there is a very clear growth of the cell, causing some doubt there. Probably this is how it goes in a long run when you follow up these cases. And of course, since it is getting time there, and I think probably this is double stent strategy, what we do here. I have done a DK crush with the crushing there. And after the crush, this is the proximal first cross, which we do. And this is the first kiss, what we do. And this is the stenting. And after the stenting and pot, you go for probably a mid or a distal cross in this. And then you can clearly document on an OCT. And this is the final kiss with a very good result. In a two-stent strategy, this is what you should aim. It should be a clear figure of 8 with good opposition without any metal bridging there. So, and I think I will just come back to the first slide. So these are the important points we should look into bifurcation. These are the points what we use using OCT in bifurcation. Thank you very much.
Oh, no, thank you. Thank you, Dr. Srinivas, for this wonderful time. And I think there was a little bit discussion that was happening on the chat box, and Mahesh asked that question to us, whether after doing imaging for some time, whether you really develop a sort of insight into the stent sizing and length, and whether you really require imaging in all cases. So I did reply back to him saying that I do not agree with the so-called OCT eyes. At least I haven't got it in spite of 6 years of OCT and 20 years of IVIS. So I did ask Dr. Kevin for his comments too, and I think it's very revealing what Kevin said. He said also I have shown on OCT. See, I had the same thought. I've been imaging for a while. I've retrained my eye. I'm better at sizing than I used to be. Then I saw my own personal light lab data. What I learned is angio is a blunt tool. 70% change in size or length by either a 0.25 size or a 5 mm length. That's really a good data, Dr. Kevin. What do you say?
Yeah, the other thing about it is, we're going to look at this in light lab because there's a smattering of older people like me that had been doing OCT since it was approved in the US, and then brand new users. And so we hope to look across that to see if there's differences in operator experience in terms of how it changes decision making. That's one of the ongoing analyses. But I'm probably, other than Haram Becerra, I think within Light Lab, I probably had the second or third most OCT experience of all the investigators. So one of two things is the conclusion. Either I never learned how to read an angiogram in fellowship, or an angiogram is a really bad way to size the vessel. And that's why I let that other anecdote in the chat. We run a very well-attended complex PCI course with 50 interventionalists every time we run it quarterly. And I have one OCT training of a proximal LED where I poll the audience and have them choose their stent size, diameter, and length. And only one person to date of 250 has chosen the right stent size and the right post dilation. And we've seen this as the arteries get bigger, it's harder to size them based on the angio. You know, I think most people can figure a 225 artery within reason if you're just going to do the angiographically, and the hazard there is less. But as we start talking about the proximal LED where it really matters, I don't guess anymore. I know with certainty and do the best thing for my patient, which is to use imaging to guide what I'm going to do.
Thank you, Kevin, for your comments.